Good day. I'm Washifa Isaacs. I'm your Notifiable Medical Conditions Coordinator for the Western Cape. Today we're going to speak about notifiable medical conditions case definitions, and we'll start with Category 1. The outline will be One Health approach. Who is NICD? NMC regulations. Who should notify and failure to notify. NMC Category 1, your case definitions and procedures. One Health approach in South Africa. South Africa's Centers for Disease Control and Prevention embraces a transdisciplinary One Health approach to making Africa safer and healthier for humans, animals, plants, and their shared environment. Here we have a map of Africa, and here you can see all the neighboring countries to South Africa, and that is where the threat will come in with anybody traveling in or moving over with a notifiable medical condition. So who is the NICD? The National Institute for Communicable Diseases is a South African body that monitors outbreaks, conducts research, and communicates information and updates on communicable diseases. The NMC regulations, we start off with International Health Regulation of 2005, who controls your border and trading, Global Health Security Agenda, and that forms part of your Centers for Disease Control and Prevention of Communicable Diseases, National Health Act 61 of 2003, and within that there is a framework for structure and uniformity within healthcare settings in the Republic of South Africa, your NMC Surveillance and Control Regulations of 2017, and that's been extrapolated directly from the Government Gazette. Who should notify? Any healthcare provider who diagnoses a patient with a notifiable medical condition. So that will be all your doctors, nurses, clinical associates, and that's also doctors, nurses working within any NGO or research project, and laboratory staff. Failure to notify is a criminal offence, and there is a jail term of not exceeding 10 years imprisonment, and that will be determined by your court of law and your practice body, SANG for nurses and HPCSA for doctors. NMC categories. Category 1 has to be reported within a 24-hour period, Category 2 within a 7-day period. You do not have to wait for a lab report for Category 1 and Category 2. The minute you have enough clinical suspicion, clinical evidence, and you've made a unanimous decision with your clinical team or infectious diseases specialist, you go ahead and do the notification on your app, or if no app available, on paper. Your Category 3 and Category 4 are also to be notified, but not by nurses and doctors, only by the lab. So the lab has a responsibility to notify all 4 categories of NMCs, that's private and public, but to note that your lab only will send back to you your notifiable medical conditions lab reports and no clinical information. The clinical component rests on to doctors and nurses for Category 1 and 2 to do the notifications. Category 3 and 4 does not have to be notified by a nurse or a doctor. Category 1, we have a list of all the notifiable medical conditions. There are up to 27 conditions. So we are going to go through the case definitions for each of these conditions. NMC case definitions for Category 1 as compiled by scientists from the NICD. Acute flaccid paralysis, or AFP, epidemiology. It is a clinical syndrome and collection of signs and symptoms instead of a diagnosis. It can be defined as an acute onset of paralysis, reduced muscle tone with children under the age of 15 years and not caused by injury, or any person of any age who presents with paralytic illness if polio is suspected. The spread is oral fecal. Your incubation period is 7 to 21 days. The causes for AFP, so many infectious and non-infectious causes. Your poliovirus, that is the natural circulating strain. There's also global monitoring to identify any clinical cases. Cases are then investigated to see if it is caused by the wild poliovirus. Other causes of AFP may be Guillain-Barré syndrome, vaccine-derived poliovirus, non-polio enterovirus, adenovirus, acute West Nile virus, Campylobacter species, transverse myelitis, peripheral neuropathy, acute non-bacterial meningitis, tick paralysis, and brain abscess. The above may be differential diagnosis of AFP. The signs and symptoms. So general symptom of acute paralysis of the lower extremities characterized as flaccid without other obvious causes, for example, trauma. Characteristic of AFP, it is always asymmetrical in distribution, involving one leg or arm and rarely affect both limbs. Signs and symptoms will depend on the cause. Your EPI disease conditions for reporting and investigation. Your disease, that is the acute flaccid paralysis or suspected polio. Your professional case definition, any case of acute flaccid paralysis, irrespective of the diagnosis in any child less than 15 years or any patient of any age who is diagnosed as polio by a medical officer. What actions need to be taken? So you need to obtain an EPID number immediately from your provincial EPI surveillance manager. That's the expanded program for immunization manager. At the following details, and alternatively, you can contact your provincial CDC coordinator. You have to collect and send 2 stool specimens 24 to 48 hours apart within 14 days of the onset of paralysis to the National Institute for Communicable Diseases via the NHLS route, and the stool specimens must be forwarded to the NICD. They are the only accredited lab to perform these tests for looking for the wild polio viruses in South Africa. Arrangements have been made with the NHLS from Tygerberg Hospital Virology, Red Cross Hospital, Groote Schuur Virology, George Hospital and Pathcare Head Office to send stool specimens or rectal swabs of AFP cases to the NICD. Your rectal swabs also need to be 24 to 48 hours apart. They are acceptable if you are not able to obtain a good stool sample. The completed AFP case investigation form must accompany the specimens to the laboratory with your EPID number. If 14 days after paralysis has elapsed, please collect the required stool specimens, rectal swabs as soon as possible. Complete and forward the South African Acute Flaccid Paralysis AFP case investigation form, your neurological assessment form and notification form, and then copy to all your focal persons from your district, sub-district, province, as well as national. And that can be done via email. The fax number is currently not working. Evaluate and conduct a follow-up examination after 60 days for incomplete investigated cases. For example, AFP cases that did not have 2 adequate stool specimens, which were 24 hours apart within that 14-day period of paralysis, transported to the NICD on ice to ascertain if there is any residual paralysis. Clinical notes and other investigations, your lab reports, clinical examination must also be submitted. Cholera. Epidemiology and surveillance. So cholera is a bacterial disease caused by infection with toxin-producing Vibrio cholerae, O1 or O139. Vibrio cholerae is a species of gram-negative, facultative, anaerobe, and comma-shaped bacteria. Earlier notification of suspected cases will ensure diagnosis is confirmed early. Measures are implemented to prevent additional infections. The transmission of cholera. So the organism is transmitted through contaminated water or food. It's usually associated with poor water sanitation and hygiene infrastructures. Causes large outbreaks and epidemics, usually in developing countries. Cholera may be imported by travelers to areas endemic for cholera or experiencing a cholera outbreak. Who should do the notification? So it's all your healthcare workers who identify any suspected case. They need to notify the healthcare authorities immediately. Please do not wait for any lab confirmation before you're doing the notification. A suspected case definition in an area where the disease is not known to be present. A suspected case is defined as a patient, irrespective of age, with severe dehydration or death from acute watery diarrhea. In an area where there is a cholera outbreak, a suspected case is defined as a patient who develops acute watery diarrhea with or without vomiting. Suspected case definition. Remember, your children under 2 years can be affected by cholera and need to be treated immediately. Your probable case definition is a suspected case with an epidemiological link to a confirmed cholera case. A confirmed case definition is confirmed when toxigenic Vibrio cholerae serotype 01 or 0139 is isolated from any patient with diarrhea. Be on high alert for cholera in South Africa. So in South Africa, we have confirmed cholera cases, and it's been reported from 5 provinces: Gauteng, Free State, Mpumalanga, Limpopo, and the Northwest. Vibrio cholera 01 serotype Okawa has been isolated, and it's been found to be sensitive to ciprofloxacin. Increased local transmission and geographic spread in South Africa. So always be on high alert for suspected cholera cases in any person with acute watery diarrhea, regardless of a travel history. The spread is also by ingestion of water, which is contaminated with your human stool, can be direct or indirect. Person-to-person spread is very rare. The infectivity period, so incubation is the time it takes from ingestion of the contaminated water or food to the time when the symptoms appear. It may be from a few hours to 5 days, and mostly after 2 to 3 days. Always remember, if the client is not symptomatic, they can still be highly contagious. Signs of severe dehydration. There's sunken eyes, fast breathing, muscle cramps, decreased skin turgor, renal failure, circulatory failure, and arrhythmias. Additional notes, your clinicians who suspect cholera should contact the NICD 24-hour hotline on 080-021-2552 for assistance with any specimen collection and diagnosis. It is essential to collect your stool specimens from suspected cases using the correct procedures and complete a case investigation form to provide authorities with information to identify the source of the cholera. For all guidelines on cholera, you can go to the NICD homepage from Google, scroll down to disease list A to Z, click on C for cholera, and once you click that, you will find all guidelines, frequently asked questions, as well as your case investigation form, your contact line list for the management of cholera. The next one, congenital rubella syndrome and rubella, the epidemiology. So congenital rubella syndrome is a major complication of rubella infection. Pregnant women acquire it and pass it on to their unborn babies. It is caused by the Toga virus of the genus Rubivirus, and mild viral infection usually ensues. Rubella. So the rash with rubella, there is a maculopapular rash, and you will find that it does not come together, it does not coalesce. It's usually milder than the measles rash, and it begins on the face and the head and then spreads downward to the rest of the body. Usually the rash will last for 3 days, unlike measles, which usually lasts for 4 to 8 days. Your post-auricular area is just pointed out to you, where you can look for glands, and then also the suboccipital area on number 8 to look for glands, especially in children. Your congenital rubella syndrome, the suspected clinical case definition. So it is any infant under the age of 2 years with a heart disease and or suspicion of deafness and or one or more of the following: eye signs, white pupil, diminished vision, nystagmus, smaller or larger eyeball. Suspect if the mom has a history of a confirmed or suspected rubella during a pregnancy, even if your infant has no signs of congenital rubella syndrome. The risk is usually higher from week 0 to 12 after the last menstrual period, and that risk may increase to up to over 80%. Infection before the last menstrual period presents a negligible risk for the embryo. In case of later infection, that's between week 15 and week 30 after the LMP, your risk decreases to about 30%, and then again it increases to reach almost 100% after week 36. Infants are infectious to the contacts after birth, so watch out for that period, which is at least 1 year after birth, where they are usually shedding large quantities of the rubella virus in their pharyngeal secretions as well as their urine. An infant in whom a healthcare worker detects at least 2 of the complications listed in A, or 1 complication in A and 1 in B, is considered clinically as a confirmed case definition. So A cataract or cataracts, congenital glaucoma, congenital heart disease, loss of hearing, pigmentary retinopathy, that's a salt and pepper look, purpura, so that is B, purpura, splenomegaly, microcephaly, mental retardation, meningoencephalitis, radiolucent bone disease, that is fatty or fluid tissue in the bone, jaundice that begins within 24 hours after birth. Rubella case definitions. So a lab confirmed case is a suspected case with a positive blood test for rubella specific IgM. Your blood specimens, which are obtained 28 days after the onset of the rash, usually. Healthcare workers should suspect rubella when your patient presents with a fever, maculopapular rash, and cervical, suboccipital, or post-auricular adenopathy or arthralgia or arthritis. Your classical trade of rubella, so the cataract you look out for, cardiac abnormalities, and deafness. So that's the 3. And other manifestations like growth retardation, rash, hepatosplenomegaly, jaundice, meningoencephalitis, and then also your central nervous system defects that may lead to moderate or profound mental retardation. These are just pictures of what your white pupil cataracts will look like, skin lesions on a baby, and retinopathy, and also nystagmus in infants with congenital rubella syndrome. So note that the nystagmus may be horizontal, vertical, or rotary. Those are just examples of what it looks like. Your lab confirmed case definition for the congenital rubella syndrome. So it is positive blood test for rubella specific IgM and or is PCR positive for rubella virus from any clinical specimen. It may be blood, lens tissue, urine, or from CSF. Your confirmation, of course, of CRS. Then a positive rubella IgM test, but does not have clinically confirmed CRS, is also classified as having congenital rubella infection. And these cases should also be notified. Notes on CRS and rubella classification. So suspected congenital rubella syndrome cases from the lab should be investigated for the syndromes or defects mentioned in the VPD, that is your vaccine preventable diseases guidelines, using the CRS-CIF case investigation form to assist in the classification. Information, CRS-CIFs assist the CRS program in classifying the cases into different categories, such as MR vaccine is included in the EPI program for 2024. Your healthcare workers to be screened for rubella. Pregnant mothers need to be screened for susceptibility with antibody testing. Women intending to become pregnant, and if they have a test for rubella and they are found to have not enough antibodies and they do a vaccine, they can prolong the conception for at least a month before they try to conceive. Specimens and the case investigation form for CRS, your diagnostic testing for fever or rash surveillance. Need to complete your measles and rubella CIF and blood for serological testing. Optional is to also have a throat swab or a urine sample for PCR testing, but the NICD would usually additionally request that. Submit your samples to the NHLS and they will send it on to NICD, where they will test for measles and rubella IgM antibodies. You also need to submit reports on any adverse events following immunization to the Med Safety application, and that is the address, web address for that. This is just a measles rubella case investigation form that has to be completed, and that can be found on the NICD's website. On the home, NICD home, disease list A to Z, you can just type in rubella or measles and you will be able to download a case investigation form. COVID-19, to remember that this is still notifiable as a category 1 NMC. Only notify your probable and confirmed cases, no suspected cases to be notified, please. Probable case definition is any person of any age positive for SARS-CoV-2 using an antigen-based test, and that is asymptomatic and not a close contact of a confirmed case, or a person of any age that has COVID-19 related symptoms, and that is a close contact of a confirmed case, or a person aged from 0 to 19 years meeting the case definition of multisystem inflammatory syndrome in children and with positive SARS-CoV-2 antibody or antigen-based test, or a close contact of a confirmed case, but SARS-CoV-2 PCR is negative or PCR was not done. A confirmed COVID-19 case definition, person of any age with lab confirmed SARS-CoV-2 infection using a PCR-based test, irrespective of clinical signs and symptoms. So that also includes your MISC with SARS-CoV-2 PCR positive, or a person of any age positive for SARS-CoV-2 using an antigen-based test, and that has COVID-19 related symptoms, suspected case, or is a close contact of a confirmed case. Diphtheria. The epidemiology, so your causative organism will be your toxin-producing strains of Corynebacterium diphtheriae or Coryn ulcerans or Coryn pseudotuberculosis, bacterium that causes necrosis of the tissue, then it results in respiratory obstruction, renal failure, neuropathy, and myocarditis. If left untreated, it may cause heart failure and death. The spread is via respiratory droplets or direct contact with infected skin lesions from an infected person. 50% mortality rate in the absence of an antitoxin. So the person may also present with cutaneous lesions caused by non-toxigenic or toxigenic strains. The cutaneous lesions may serve as a potential reservoir for the transmission of toxigenic and non-toxigenic Coryn diphtheriae. Immediate notification is essential. Your response to a suspected or confirmed diphtheria case. So it's rare, the disease, and clinicians need to have a high index of suspicion to make an early diagnosis. Rapid contact tracing needs to be done, testing of any close contacts with signs and symptoms, the administration of appropriate prophylactic antibiotics, and your vaccination can also help to contain the outbreaks. Remember, you are notifying notifiable medical conditions to contain the spread of an outbreak also. So suspected case definition is a person who presents with an upper respiratory tract illness characterized by a sore throat, a low-grade fever, and an adherent membrane of the nose, the pharynx, the tonsils, or the larynx. A probable case definition is any person with upper respiratory tract illness characterized by sore throat, low-grade fever, and an adherent membrane, which can also be called a pseudomembrane of the nose, pharynx, tonsils, or the larynx, and with or without swollen neck, and it's often also called a bull's neck, or a person who has an epidemiological link to a confirmed case, has a respiratory tract symptom, but no membrane, or a person with a skin lesion, and so Confirm then with chorine diphtheria or chorine ulcerans or chorine pseudotuberculosis if it has been isolated from your relevant specimens, but the toxigenicity status has been confirmed. These are pictures of a pseudomembrane in the first picture A, and also a bull's neck in a child with diphtheria. And then you have on the right side lesions on a neck of an adult and a lesion on the leg also of an adult. There's also just more examples of a pseudomembrane in an oropharynx. So if you look to the one on your left, you'll see the white patches. If you scrape that or you try to remove it with a swab, it usually does not move away. It does not come off. And that's also a good indication that it might be diphtheria. If you look at the pseudomembrane on the right, there you can see that the pink is no longer as pink. It has already started to turn a grey bluish color, and you can see the adage of the membrane. If you hold it down with a spatula, you will be able to see it much clearer. Got a confirmed case definition. So signs and symptoms consistent with diphtheria, respiratory and or cutaneous, and a positive culture for or PCR detection of chorine diphtheria or chorine ulcerans or chorine pseudotuberculosis from a clinical specimen is confirmed to be toxgene positive by PCR or toxin producing by ELIC testing. Who to contact? Your clinicians who suspect diphtheria should contact the NICD 24-hour hotline on 080-021-2552 for assistance with specimen collection, your diagnosis, and how to manage a case. What specimens to collect? So a throat swab of any suspected diphtheria case, ideally below your membrane, using a dacron, rayon, or nylon flocked swab placed in Amy's or modified Stewart's transport medium with charcoal. This can be obtained from your local NHLS laboratory or private lab. This must also be transported on ice to the laboratory, clearly labeled suspected diphtheria. Treatment management of a case. So the diphtheria antitoxin is part of treatment. It is in short supply globally. So we also have limited supplies available in South Africa. Use it appropriately. Always consult with your infectious disease specialist. And also note that in the absence of antitoxin, appropriate antibiotics and supportive care should be given. Treatment continuing. Start your treatment prior to your lab confirmation. You do not have to wait for lab confirmation. Enough clinical suspicion. Should you have that, you start the treatment. Isolate your patient to prevent transmission of the chorine diphtheria. Practice your contact and droplet precautions. Supportive care is also necessary. For example, oxygen, your ECG, intubate your patient, or perform a tracheostomy if necessary. Submit your case investigation form and a contact line list, and also your notification form on the app, or if you don't have the app on paper. Laboratory management. It is recommended to labs to routinely screen all oropharyngeal and nasopharyngeal swabs for chorine diphtheria, swabs from abscess or cutaneous lesions to be screened for chorine diphtheria if cutaneous diphtheria is clinically suspected, and or if it is part of a chorine diphtheria outbreak investigation within that sub-district, district, or the province. Your public health actions following the diagnosis of a diphtheria case: intensify surveillance, notify on time, report all suspected, probable, and confirmed cases immediately to, if it's in a hospital setting, infection prevention and control, or to the closest hospital setting if you are in a primary healthcare setting. Your practitioners, where applicable, should then take action, and they will also inform the district, provincial, communicable disease control coordinators, and any other focal persons urgently. This has to be done so that there is collective action being taken to control that outbreak and reaching out to all the close and vulnerable contacts with regards to post-exposure chemoprophylaxis or vaccines. Your public health response to a case or outbreak to diphtheria. So again, just to reiterate, your case investigation form, your line list, and your contact line list. So the line list is starting from the hospital setting of all the close and vulnerable contacts within that setting or your primary healthcare setting. The contact line list is then forwarded on to the sub-district focal persons, and they will then continue and conduct the contact tracing and complete the contact line lists of any other contacts within that community, household, or any other person from workplace or schooling, whoever that person has been in contact with outside of your hospital setting. And also to identify all the close and at-risk contacts appropriately. Again, your public health response to the case or outbreak is continued, so your lab investigation needs to be done for all your close contacts. Administer the chemoprophylaxis to all close contacts. Vaccinate and do catch-up vaccination as part of your expanded program for immunization with children. Remember that all adults can also be vaccinated. Alert all healthcare workers in that area. All healthcare workers who wish to be vaccinated can also be vaccinated. Conduct health promotion and education widely, and target your at-risk groups with vaccine campaigns where need be and where resources allow. Your diphtheria guidelines and reporting investigation forms, again, can be obtained from the NICD homepage. That is at the diseases A to Z list. You can just click on D for diphtheria, and you will find all the information available to you on the recommendation for diagnosis management, your public health response, notifiable medical conditions, your case investigation form. You can download your contact line list from here, as well as your alert to your healthcare workers, and then also a FAQ and your case definition flip chart to assist you with your management. Enteric fever, typhoid or paratyphoid fevers. So the epidemiology is it's caused by Salmonella entericus serotype typhi, and that's usually the cause of your typhoid fever, or Salmonella entericus serotype paratyphi A, B, or C, which cause paratyphoid fever, a disease clinically indistinguishable from typhoid fever. It's transmitted by fecal-oral route or by the ingestion of contaminated food or water. Note that it only affects humans and they are the only reservoir. Suspected, probable, and confirmed case definition. So it's any person presenting with a fever for at least 3 out of 7 consecutive days, and suggestive symptoms include your gastrointestinal symptoms. And note that the abdominal pain, nausea, and vomiting, diarrhea is usually present in the younger age group, and constipation is more common in the older children and adults. Also headaches, malaise, hepatosplenomegaly, or hepato or splenomegaly, erythematous maculopapular lesions, so like rose spots. It can be flat, faint pink spots of 2 to 4 centimeters in diameter, which develop on the chest first, then abdomen and back. And a travel within the last month to an area known to be endemic for enteric fever, or where an outbreak of enteric fever is ongoing, or the absence of an alternative diagnosis in persons with no travel history. A probable case definition is a clinically compatible case that is epidemiologically linked to a confirmed case. Then confirmed The isolation of Salmonella enterica serotype typhi or Salmonella enterica serotype paratyphi A, B, or C from a clinical specimen in the presence of symptoms which are compatible with enteric fever. Please note serological tests, including the Widal test, have a poor sensitivity and specificity and should not be used to make the diagnosis of enteric fever. Complicated cases, there may be organ failure. Your lab test will advise you. Traveling patients, consider an alternative diagnosis if you do not test positive, if the patient's test does not come positive for your enteric fever, then it could be dengue or malaria or even any kind of hepatitis. Specimens for diagnosis and treatment of enteric fever. So it's usually isolated from blood, bone marrow, feces, urine, or a sterile site. However, bone marrow biopsies are invasive, specialized procedures. Therefore, your blood culture will be your gold standard for the test for enteric fever. Collect your blood culture before you start any antibiotics, and you must always try to make use of appropriate antimicrobial treatment. Other forms and follow-up, you notify on the NMC app. If it's a hospitalized patient, complete the hospitalization form as part of your clinical notification. Note that this is not available on your mobile app, so you have to do this on a web computer in order to access the hospitalization form as well. Complete a case investigation form in addition to doing your notification, and submit a copy to your environmental health practitioner for that sub-district, and send copies of your NMC also to that patient, to that person. Ciprofloxacin is the empiric treatment of choice for uncomplicated cases in South Africa. Tailor your antibiotics according to the susceptibility test results which are available. Following confirmation of the diagnosis and completion of antimicrobial treatment, serial stool cultures are performed. Ensure infection is cleared and patients are not carriers. Your public health officials from your district office should identify the household contacts of confirmed cases. They need to obtain stool specimens or rectal swabs also from them to identify and treat these contacts who are the carriers. Foodborne disease outbreak. It's usually an early identification of a foodborne illness outbreak. Authorities need to investigate the outbreak timeously, collect appropriate specimens, identify the outbreak sources, and implement interventions to prevent additional cases. Your suspected case definition: 2 or more persons experiencing a similar illness, for example, a gastrointestinal kind of symptoms, and epidemiologically linked. Note there are no confirmed case definitions for foodborne illness. The outbreak is a clinical and epidemiological diagnosis, and so no lab reports are required for this. What you need to do. Your healthcare worker who makes the diagnosis should notify the outbreak. Complete your NMC notification for the first 2 index cases only. Submit your line list of affected persons. So on there you will have name, surname, date of birth, the what they've eaten, when it started, to the responsible communicable disease control coordinator, and also to the responsible environmental health practitioner, as well as NICD. Stool and or vomitor specimens and food environmental specimens should be submitted to the NHLS. But that is just additional. They just want to obtain that to establish a pattern maybe of the same type of pathogen, and if it's food and environment, just to ensure that it was actually caused by that particular food that a group of people have eaten. Complete your case investigation form with additional data and the results. So including results of your lab testing of your clinical and food specimens on your additional data that you are going to add on, and the symptoms, clinical features of the affected persons, the menu and the list of foods offered at that implicated meals that they ate at that particular restaurant or food outlet, complete your food consumption history from affected and non-affected persons, and also investigation of the food handlers, whether they are not maybe infected priorly to preparing that food. So where to find your case investigation form or any information for lab, the NICD NHLS Quick Reference Guide for the Investigation of Foodborne Disease Outbreaks of 2012. There's a line list, also case investigation form, and your specimen submission forms for NHLS Public Health Laboratories will be available on the NICD's homepage, disease list A to Z, so you can just click onto F for foodborne illness, or also the gastroenteritis outbreaks. Listeriosis. So this is a foodborne illness, and it's linked to a range of contaminated foods, including ready-to-eat meats like your processed meats, dairy products, and fresh produce. It may result in bacteremia, meningitis, and also fetal loss, unfortunately, if the mom miscarriages during her pregnancy. Immunocompromised persons, pregnant women, and the elderly are more at risk of developing the disease, and also the very young. So all the cases need to be notified and investigated, that the potential outbreak and possible sources are identified timelessly and stopped in its tracks. Confirmed case definition, your isolation by culture or detection by PCR of Listeria monocytogenes in any clinical specimen. Note there are no suspected case definitions for FBI. It may present with a wide range of symptoms and non-specific clinical syndromes. Lab samples, so you can collect stool for microscopy and culture, and also sensitivities. And fever within 24 hours of clinical assessment. Consider routine blood cultures if there is that high fever. Evidence of systemic involvement, which will be signs like a headache, stiffness, confusion, loss of balance, flu-like symptoms, and or in your over 65 years, particularly if there's a history of a preceding gastroenteritis, then do a routine blood culture, a lumbar puncture also for suspected meningitis, meningoencephalitis, and then a culture of any other potentially affected anatomical site. Responsibilities, so your labs, private and public, must submit all isolates of Listeria monocytogenes to the NICD Centers for Enteric Diseases for molecular typing. Your healthcare worker should notify, your environmental health practitioner should do a detailed food history obtained using the listeriosis case investigation from all persons with listeriosis or their next of kin, or the mother if there was any fetal loss. And then to remember also your hospitalization form. And as I said before, it is available only on your web computer platform as part of your NMC online notification. And it is actually recommended that you complete this hospitalization form for your patient while your patient is still in hospital. Where again to find any information on enteric on your disease, you can go to your disease list on the NICD homepage for listeriosis, and just click onto L for listeriosis, and it will give you a whole range of management and information. And your center for the enteric diseases at the NICD, you can contact Dr. Juno at NICD. So her email is junot@nicd.ac.za, or you can call her on a mobile or to the office, and she will answer any additional questions that you might not have found on the website. So now we go over to malaria. The epidemiology for malaria. So it will start off with systemic febrile infection. Malaria is caused by 5 species of mosquito-transmitted protozoal parasites. generally acquired in known risk areas, but occasionally associated with blood transfusions, needle injuries, and imported mosquitoes in non-endemic areas. Notification of cases is essential to track the disease burden in endemic provinces and to investigate the reason for imported cases in a non-endemic area. Who should notify? It's all your healthcare practitioners who make that diagnosis, and this should be done immediately. A positive rapid test, so a point of care test for malaria, once that is confirmed, a positive test from a blood specimen submitted to your lab also, a suspected case definition in an endemic area, an acute febrile flu-like illness in a person with a history of exposure, or in a non-endemic area, an acute febrile flu-like illness with a history of blood transfusion or injections, or a FI with no other cause for illness and compatible non-specific laboratory findings, especially thrombocytopenia. Probable and confirmed case definition. So probable is clinically suspected case in a recognized malaria outbreak or endemic area. A confirmed case is a positive malaria test, blood smear, rapid antigen PCR for any of the species. So it's P. falciparum, P. vivax, P. ovale, P. malariae, P. knowlesi. Responsibilities. In non-endemic areas, malaria cases should be notified on the NMC app or on paper by completion of the NMC form. Complete your national case investigation form. Send that to your environmental health practitioner. Cases where no travel history and entomological assessment of the house and geographical location of residents must be conducted by your EHP to find mosquito breeding sites and kill the possible Plasmodium species larvae. Where to find your resources? Again, go to the NICD homepage. You can just go in for malaria and you will find all your guidelines and management and also your FAQ there. Measles. The epidemiology for measles, it's a highly contagious infectious viral disease, transmission by the respiratory route usually. 90% of individuals who are exposed will become infected. It's caused by measles virus, member of the viral family, Paramoxiviridae, also known as morbillivirus, and causes a morbilliform rash. Your key characteristics are prodromal symptoms with subsequent exanthem, measles risk factors, so vitamin A deficiency, malnutrition, immunocompromised, vulnerable persons, pregnant women, very young and very old persons. Your measles clinical features, we have 4 stages. Stage 1 is the incubation period, stage 2 prodromal period, and stage 3 the exanthem period. Note the Koplik spots prior to the exanthem. Measles clinical features continuing. It occurs 48 hours prior to the official exanthema, lasts for more than 72 hours. It only occurs in 80% of measles cases. Other findings will be lymphadenopathy, pharyngitis, diarrhea, and continuation of the prodromal symptoms. In stage 4, there will be recovery, so improvement in the symptoms will occur 48 hours after fading of your rash. There may also be post-infectious symptoms, persistent cough that can last for weeks, and then there is also in the recovery, lifelong immunity. Measles and rubella elimination definition. So it is defined as no endemic measles or rubella transmission in a country for more than and equal to 12 months in the presence of a well-performing surveillance system. Who should notify? Any clinician who suspects a case should notify immediately. Do not wait for a lab confirmation. Your suspected case is any case in whom a clinician suspects measles infection or any person with a fever and maculopapular rash that is non-vesicular and one of the 3 C's. The 3 C's is your cough, coryza, conjunctivitis, and then your probable and confirmed case definition. Probable, a suspected measles case with an epidemiological link to a known measles case. Confirmed case, a laboratory confirmed measles case is any person with clinically compatible measles and a measles-specific IgM result in any specimen or a positive measles PCR test on a throat swab. Also, a clinically compatible case, according to the World Health Organization, is a case that meets the clinical case definition with no blood specimen submitted or without an epidemiological link to a confirmed case. Complications occur during 30 days after the rash onset, so there may be diarrhea, otitis media, pneumonia, encephalitis, miscarriage, or premature birth for pregnant ladies. Risk for severe complications is greater in your children under the age of 5. If they're also living in overcrowded conditions, and also if they are malnourished, or with a vitamin A deficiency, and children who are immunocompromised with advanced HIV infection, for example. Also adults who are older than 20 years. Case fatality rate is usually 3 to 6% in developed countries. It's rare, usually 0 to 1%. And in humanitarian emergencies, it can be up to 30%. Your clinical management, symptomatic and supportive treatment, suspect measles in children under the age of 5, irrespective of the timing of the previous doses of your vitamin A. You should administer a dose of vitamin A on diagnosis. That's dose 1. Your second dose of vitamin A the next day. Your third dose of vitamin A 4 to 6 weeks later if signs of deficiency show. Nutritional support is recommended to reduce the risk of malnutrition due to diarrhea, enhance your breastfeeding appropriately. Oral rehydration salts to be used to prevent the dehydration. Vaccination is there to prevent your secondary infections. So in unimmunized or insufficiently immunized individuals, measles vaccine may be administered within 72 hours of exposure to the measles virus. Your case investigation form and lab specimens. So all suspected cases have to have a case investigation form completed, submit a blood specimen for measles, and they will test for specific IgM within that 28 days of symptom onset. Your EPID number, you need to get that from your sub-district office in your district, and also sometimes, like for City of Cape Town, it is available from the Provincial Health Office. You can send a copy of the case investigation form with your lab request form and your sample to the NHLS. If you test positive for rubella, IgM, then complete the combined measles and rubella case investigation form. So to remember that. Where to obtain your EPID numbers, there's just a list here which you can actually take and you can print it out, put it up into your clinic room so that you have it. This is for the Western Cape. So they have it available for every district. So for the City of Cape Town, there's the number for your Provincial EPI Disease Surveillance Manager, your Cape Winelands office, Central Karoo, Eden, Overberg, West Coast. Where to find resources, again, from the NICD's website. Meningococcal disease epidemiology or causative organism is Neisseria meningitidis, present as meningitis, septicemia, respiratory or focal infections, spread through droplets or intimate contact with nasopharyngeal secretions. Your incubation period of meningococcal disease is 3 to 5 days. Meningococcal disease should be notified immediately. Prevent additional cases by giving chemoprophylaxis, antibiotics to close and vulnerable contacts. That is just a picture to show in an infant and young children. The child may have a dislike of being touched, extreme tiredness, irritability, drowsiness, a dislike of light, nausea or vomiting, refusal to eat. The rash can be red, purple, pinprick spots or larger bruises. And below is just a meningococcal bacteria showing under a light of the microscope. Meningococcal meningitis rash in adults. It can be also like a septicemic, where the capillaries underneath the skin has been broken up and it's causing bleeding, right petechial spots right underneath the skin, or purpura fulminans. Who should notify is all your clinicians who suspect it. suspecting a case of meningococcal disease, and immediately this should be done, and also your lab results. Your lab report sent so that you can have your lab results also available. Your health authority should identify any contacts and administer the post-exposure chemoprophylaxis as soon as possible and as soon as a lab has confirmed that it is that condition or disease. A suspected case of meningococcal meningitis is septicemia or other invasive disease, orbital cellulitis, septic arthritis, where the physician considers that meningococcal disease is the most likely diagnosis. Your cases may present with fever, a petechial rash, and may progress rapidly to purpura fulminans, shock, and death. A suspected case is regarded as a probable case. A confirmed case is when they isolate the Neisseria meningitidis from a normally sterile site specimen, for example, blood, your CSF, pericardial or synovial fluid, or a positive gram stain and latex result, or a positive PCR result. Although not meeting the case definition, meningococcal conjunctivitis is considered an indication for public health action because of the high immediate risk of invasive disease. Where can you find your information? Again, on your NICD's homepage. And you can also contact Dr. Anne van Godberg at the NICD at anv@nicd.ac.za. Pertussis. So the epidemiology for pertussis or whooping cough, it is a highly contagious bacterial respiratory tract disease. Causative organism is Bordetella pertussis. It occurs mainly in infants and young children, transmitted through the respiratory secretions, highly transmissible, high mortality in children under the age of 1 year, especially children too young to be vaccinated or who have not yet completed their primary vaccination series. Pertussis also, who should do the notification for these cases? Your clinicians should notify the cases on the basis of clinical suspicion. They do not have to wait for lab confirmation. Also note that you have to send a follow-up report of what follow-up you have done, your management, as well as which contacts have been identified and who has been treated or given post-exposure chemoprophylaxis and the catch-up vaccines according to the EPI program. That report can be sent to your sub-district office, your district office, as well as to the provincial health department, please, so that we can see that you have indeed closed the loop of infection. A suspected case, probable and confirmed. So we start off with suspected is any person with an acute cough illness lasting for more than and equal to 14 days, a cough illness of any duration for children under the age of 1 without a more likely diagnosis, and one or more of the following signs and symptoms. So it could be paroxysms of coughing, inspiratory whoop or post-tussive vomiting, or apnea in children under the age of 1, or any person in whom a clinician suspects pertussis. A probable case is any person meeting the clinical case definition and an epidemiological linkage to a lab confirmed case of pertussis in the 21 days before the onset of the symptoms. A confirmed case is any person meeting the clinical case definition and there is isolation of P. pertussis from a clinical respiratory specimen or polymerase chain reaction positive for pertussis or specific antibody response, that is your anti-pertussis toxin IgG response in older children and adults, and the person is under the 1 year or equal to that one over 1 year after the last vaccine dose. You must always try and interpret your results with caution in younger children. So always make use of experts in your facility. Your infectious diseases experts will be available to your assistance. Contact post-exposure, chemoprophylaxis, vaccination, and feedback of your outcome. As I mentioned before, please feedback to your health authorities, and your health authorities should identify all the contacts of the pertussis cases, so that will be your sub-district office. Provide post-exposure chemoprophylaxis if necessary, booster vaccination, any missed catch-up vaccines has to be done. Note that last date of the vaccine very important. If, however, you have a child coming to your setting, maybe a primary healthcare setting, and there's an older child with or a younger child, and you know that you have to actually inquire about the children's status of vaccine to ensure that the loop again of infection is closed and everyone is reached who needs to be reached with regards to the prophylaxis and vaccines. Management of a confirmed or probable case, you isolate your patient, prevent transmission of the bordetella pertussis, practicing contact and droplet precautions, provide supportive care, aims to monitor the severity of your patient's condition, limit the number of paroxysms, and maximize nutrition, rest, and recovery, treat with appropriate antibiotics, and use alternatives to prevent the transmission. Again, identify your close and vulnerable contacts, collect your nasopharyngeal swabs in Regan Low for culture and PCR. If it's not available in UTM or VTM for PCR only, from symptomatic contacts, administer your targeted chemoprophylaxis, vaccinate and close. Vaccinate your close and your vulnerable contacts, monitor contacts for at least 21 days for typical signs and symptoms, and then vaccination of healthcare workers is also important in the prevention and control of pertussis. It's highly recommended where resources will allow. Again, your resources for additional information can be obtained from the NICD's homepage. We go on to rabies. So the epidemiology for rabies transmitted through saliva of infected mammals, including dogs, mongoose, cats, jackal, cattle, and goats. After a variable incubation period of 2 weeks, the rabies virus causes dysfunction of the nervous system, resulting in encephalitis, coma, and death. Where there's no treatment but rabies post-exposure chemoprophylaxis may prevent the infection in persons who have been exposed. Cases of rabies should be notified, as canine rabies is endemic in South Africa and human exposures are frequent. Following notification of a case, investigation should ensure to determine why your post-exposure chemoprophylaxis was not correctly administered and identify your additional persons at risk. Your vet control measures should also be implemented, please. So you contact your SPCA from your local SPCA within your district or sub-district. Who should notify is all your clinicians who are suspecting a case. They should notify if it meets that clinical case definition. Laboratory confirmation is not required before notification of the case, please. Suspected cases are a person presenting with an acute neurological syndrome dominated by forms of hyperactivity, that's furious rabies, or paralytic syndromes or dumb rabies, progressing towards coma or death. Usually by respiratory failure within 7 to 10 days after the first symptom, if no intensive care is instituted. A probable case is a suspected case with a likely exposure to a suspected rabid animal. A confirmed case is a person with a laboratory diagnosis and of the rabies infection by detection of rabies virus nucleic acid by your RT-PCR on saliva, so that's your rapid test, skin biopsy, or your CSF or anti-rabies antibodies in the CIF. And then, unfortunately, for the antemortem or rabies virus antigen in the brain tissue by fluorescent antibody testing or rabies virus nucleic acid in the skin biopsy, that's also post-mortem. A negative test and your resources. So negative saliva tests for rabies do not rule out the diagnosis. If the diagnosis is not confirmed through lab tests done ante-mortem or post-mortem, a brain biopsy should be done. Instructions for your specimens collection are found on the NICD's website. So again, it is the NICD homepage you go to disease list A to Z and go R for rabies. Your human rabies statistics are based on a year of exposure and infection and may differ from a year of case notification. Viral hemorrhagic fever diseases. These refer to a number of different diseases characterized by the presence of fever, rash, and bleeding. It's caused by viruses belonging to 4 families of RNA, the Arenoviridae, Filoviridae, Bonnieviridae, and Flaviviridae. Viral hemorrhagic fever diseases, so Ebola, Marburg, and Lassa fever, Lujo virus is also part of that. And Congo fever epidemiology, your Crimean Congo fever caused by the norovirus. It's transmitted to humans through the bites of or the crushing of ticks by contact also with a person with a Congo fever during the acute phase of infection, and then again by contact with blood or tissue from a viremic livestock. So if people are working on farms or delivering a calf or a filly or assisting with that delivery and they have not actually worn gloves or proper PPE, and when that viremic blood mixes with their own, there's a high chance of them becoming infected. So your CCHF is endemic to South Africa. Ebola and Marburg hemorrhagic fevers and Lassa fever occur in Central Africa. Typically, your VHF is associated with high fatality rates in humans. Hemorrhagic fever viruses cause increased permeability of your blood vessels and bleeding. This may present as a particular rash, bleeding of internal organs, or bleeding from bodily orifices. It's not, EVD is not endemic to South Africa. Many years ago, we have had a case. The country is, however, endemic for Crimean Congo hemorrhagic fever, and although human cases are rare, cases are reported annually, so you need to know what to do. These are your common hard shell ticks that causes your Crimean Congo fever. Just to note that you become familiar with them. It's hard shell. They're usually found on farms and gaming farms, gaming areas where cattle are. So there is a life cycle, the enzootic cycle, they call it. Ticks are both a reservoir and a vector for your Crimean Congo hemorrhagic fever. The virus is maintained in nature, transovariably, and also transstadially. So cases occur more during the warmer parts of the year, mostly the spring and summer. There are no cases during winter. This is what evidence shows. Humans become infected through tick bites and direct contact with infected animals, blood or tissue. And also from that tick, it can bite the human being and then go on to the animal or vice versa. Ticks feed on numerous wild and domestic animals such as cattle, goats, sheep, birds also. And these animals serve as both food sources for the ticks and also amplifying the host for the virus. Transmission can occur while slaughtering, as I mentioned before, and during veterinary procedures, and also in hospital settings where proper protective equipment and appropriate disinfection procedures are lacking. So always try to follow proper procedures. This is just a slide to show the symptoms again of the viral hemorrhagic fever. To note that the leakage of the blood into all body cavities, causing effusions with increased bleeding under the skin and into the internal organs. It can also cause conjunctivitis and then organ failure. Who should notify? It's all your healthcare practitioners who suspect any case of, for example, Crimean Congo fever, hemorrhagic fever, and request a lab test to notify as well. Your lab that diagnoses the condition should also notify the case. That's the lab only. Clinicians then have to complete, if it's already on the system, they complete the clinical component on the NMC app. A suspected or probable or confirmed case. So a suspected case is a person with an acute onset of a fever of more than 38 degrees with at least 3 of the following signs and symptoms: severe headache, myalgia, prostration, flushing, nausea, vomiting, pharyngitis, conjunctival injection, petechial rashes, bleeding into the skin, ecchymosis, hypotension, and shock. And then look at your AST or ALT, highly elevated. There can be edema with neurological signs. And a likely epidemiological exposure would include any of the following: a history of being bitten by a tick, or that someone crushed a tick with their bare hands, direct contact with fresh blood or tissues of hoofed livestock or game, or direct contact with blood secretions or excretions of a confirmed or suspected case, including your needle stick injuries or This person resides in or visited a rural environment where contact with like livestock or tick was possible in the past 15 days. A probable case is any disease suspected case where it has not been possible to collect specimens for laboratory confirmation having an epidemiological link to a suspected or confirmed case. A confirmed case is a person with a lab evidence of infection as evidenced by a PCR which is positive, virus isolation from the patient's first single specimen, or PCR positive and IgM positive result on patient's first single specimen. PCR positive on 2 separate specimens from the same patient collected at least 1 day apart, or a PCR positive from IgM IgG negative result in patient's first specimen, and PCR negative but IgM IgG positive result in patient's second specimen collected at least 1 day apart, or increase in your IgM IgG titer between acute and convalescent specimens, or is a suspected case with IgM positive result on your patient's first specimen. Your contact tracing algorithm, so you're screening your individuals who are at risk, normally your travelers screening, and also the initial community screening gets done. If your person is found to be at risk, you will then do your monitoring for 21 days. Your evaluation and quantifying of that risk is also done within that risk assessment, and then the monitoring carries on and watching for development of any symptoms and then manage it accordingly. So if your patient has no symptoms, then there's no monitoring required and you can exit the contact tracing algorithm. If there are no symptoms, again, after 21 days, then again you exit. But you're going to ask yourself, is this a case? If it is a case investigation is then warranted. If it's a case, you have to draw up a case contact line list and conduct that contact tracing. So the vet needs to be involved as well, SPCSA if need be, your environmental health practitioners, investigate who this person, who is your index case perhaps, have been in contact with, for contact tracing, and all the animals and everything need to be contact traced. Your resources can be found at the NICD's homepage. You can just go to disease list A to Z and you can click on E for Ebola or C for Crimean Congo hemorrhagic fever. Yellow fever, acute viral hemorrhagic disease transmitted by infected mosquitoes. Remember, yellow fever is not known to occur in South Africa, but we have had imported cases. So it's important that Port Health will play that part of ensuring that when travelers return to South Africa, they have proof of the vaccine for yellow fever. If there's no vaccine, they quarantine for a week up until no signs of yellow fever is present. Your vaccination should be done at least 10 days prior to traveling to an endemic area, and that will provide at least 80 to 100% protection. Full protection if vaccinated a month prior to travel should happen to an endemic area in parts of Africa, South America, also the East. So that is where Port Health will come into play, but also your environmental health practitioner as well. So thank you very much, everyone, for listening. My details for the Western Cape is 064-742-4005, or you can email me. If you do not find your notifiable medical conditions coordinator available for your province, you may contact the NMC hotline person on 072-6213805. Thank you so much.